Hi. So we are now live. My name is Dr. Kai Hermann. With me is Dr. Ziad Risheq. We are doing this quick one session. So we have a double. We have some echo here. Unfortunately, I don't know why. And somehow. Yeah, exactly. That's not good. Now the echo is gone. Sorry for that. So we are here today to discuss nuclear medicine cases. In fact, we will speak about SPECT CT, and this session is part of our regular sessions in the Nuclear Medicine Academy that Dr. Ziad is leading. We are almost in the finishing the first year. So we started in August. So it's not long until we have the next August. So we are already overseeing 10 or 11 months of education in the field of nuclear medicine. I think the academy went well. Ziad, we have now 170 people subscribed to our academy. And yeah, great that you made it. And what do you have prepared today?
So today we're going to talk about SPECT CT in hip prosthesis. We're going to see different cases with patients presenting with hip pain or thigh pain, and most of these patients they have normal radiographs, or when they do CT, they really don't see any kind of abnormality. So SPECT CT is a really valuable modality to identify pain generators. So in this session, we're going to look at probably 4 or 5 different cases, and we're going to walk through these cases and how to interpret on how to interpret them in order to find or to come up with a proper or most likely diagnosis. So I think it's a really valuable modality, especially I know you can do MR with the metal artifact reduction and all that, but not everyone or every institution have these workflows to do the artifact subtraction or prosthesis subtraction. So if you have SPECT CT, it's a really valuable modality, and let's say in most of the cases you can come up with a diagnosis or identify the pain generator, or at least you can rule out any kind of problem or pathology regarding the prosthesis. So this is what we're gonna do in this session.
Great. So let's jump right in. I will bring up your screen, and you can take it from here, Ziad.
Yeah. So you can see my screen, right? So we have 5 cases, and we're gonna start with the first one. So this is a VRT MIP, a fused image. You can do this. I did this with Osiris, so you can do this with Osiris if you're using it. As you can see the prosthesis over here. You can see the abnormal uptake. So we'll get into that in a different session, or we're gonna do a video about this or a session on how to do these images. So the first case is a 51-year-old male with total hip replacement 9 months ago, and he presented with hip and groin pain during weight bearing and walking. The inflammatory markers were mildly elevated, and the radiographs were normal according to the report. So sometimes we don't get the full history from the patients or from the referring physician, so you have to do with what you get. Let's take a look at the planar images, because this is what every nuclear medicine physician is used to. So this is the planar scan, the delayed scan. You can see there is some kind of uptake over the acetabulum around the femoral stem. It looks normal. This is the anterior projection, and this is the posterior projection. Again, it looks kind of normal, but you have some kind of activity over here. And this is the MIP. This is the blood pool MIP. Okay, so you can see there's activity over here. And this is the delayed MIP. As you can see, you have some kind of activity over here. Let's take a look at the planner at the SPECT CT blood pool or perfusion images or the early phase images. So you have here a left hip prosthesis. As you can see, we masked the bladder over here, and you can see that there is intense activity over the acetabulum. And if we look at the femoral stem, we don't see any kind of abnormal blood pool activity or early phase activity or perfusion. This is the coronal fused images. You have some mild activity over here. This is normal. This is expected. And you have intense activity over here, over the acetabular component. On the sagittal images, we see the same uptake. And now let's take a look at the delayed images. So if you link the CT and the fused images together, you can see there is abnormal uptake over the acetabular region. And if we go down, we don't see that same intensity of uptake over the or around the femoral stem. Let's take a look at the coronal images. So you have this intense uptake, okay? And if you notice, we have an acetabular screw over here, or a fixation screw. So this tells us that this is a total hip replacement, okay? So we have intense uptake around the acetabulum, the acetabular fixation screws, and this is the second screw. And when we look at the acetabular region, we usually divide this region into three compartments or three regions. So you have, if we draw a line, a perpendicular line over here and another one over here. So you have here zone 1, and this is zone 2, and over here, this is zone 3. When we look at SPECT CT, to diagnose an abnormality, or let's say aseptic loosening, or in generally speaking, loosening, you need to see intense uptake either involving all the zones, the acetabular zones. So we have here zone 1, and here zone 2, and here zone 3. And usually we see a corresponding lucency. Or you can have an uptake over two contiguous zones, for example, in zone 1 and in zone 2, and there is a corresponding lucency. And when you see this appearance, you have to think of either septic or aseptic loosening, depending on the CT findings that you see. So if we look closer here, and we zoom over here, and you can see the diffuse uptake. Let's go back and forth. You can see that this uptake is actually involving all the zones, zone 1 and zone 2. This is the intermediate zone, and this is the medial or inframedial zone. So this uptake is involving all these zones. Now, when we look at the CT part, let me just zoom in. You can see there is a lucency over here at the bone prosthesis interface, and we don't want to see this under normal conditions. So when you see this and there is a corresponding intense FDG uptake or intense blood pool activity and delayed tracer uptake, you have to think of loosening. So this patient, and even when you look at the fixation screw, you can see some kind of halo over here. There's a cystic lucency around this screw. So when you see this appearance, you have to think of loosening. Basically, we have to think of loosening. So this patient had acetabular loosening. And let's take a look at the sagittal images. Again, you can see the same intense uptake throughout the femoral zones. But when you want to assess for the zones, you have to look at the coronal images. But we can appreciate that there is some kind of lucency over here, even though if it's probably this is less than 2 millimeter. But if there's a corresponding intense tracer uptake, this is probably loosening, whether it's mechanical loosening, aseptic loosening, or septic loosening, since we have this intense tracer uptake. So if we look, this is how I do my reporting. Again, we talked about this a lot. So first, I talk about the acetabular component. If there is migration or hardware fracture, so this looks normal in position with no evidence of fracture or dislocation. And there's intense perfusion. This is what I call the blood pool phase. You can say there is an enhancement or there is intense blood pool activity, and a delayed tracer uptake involving the acetabular fixation screws and the bone prosthesis interface. So this is what is important. We have to look at the bone prosthesis interface. So this is what we're interested in. We're not interested in any kind of uptake if it was subcortical. For example, here we have a total hip replacement, and we don't have any cartilage. Where in hemiarthroplasty, we don't have substitution of the acetabular cartilage. We have preserved acetabular cartilage. So in that case, we say we have a subchondral uptake or subchondral degeneration, whatever we see. So in this case, what we're looking at is this lucency is over here on the CT part, and it is corresponding to intense uptake. And we have a cystic lucency around the acetabular screw. You can see, let me just fix this. Okay, so we have this intense uptake around the acetabular fixation screw, and it has a some kind of cystic lucency around it. So this is basically consistent with acetabular loosening. So you can use this template for reporting. We have intense uptake, delayed tracer uptake involving the acetabular fixation screws and the bone prosthesis interface. And it is involving the superolateral, intermediate, and inferolateral acetabular zone. Let's take a look at that. So again, if we divide the acetabular region into, if we draw a perpendicular line over the center over here and another horizontal line over here. So here you have zone 1, and here you have zone 2, and here you have zone 3. So zone 2 is less significant for fixation. We're more interested in zone 1 and zone 3. These are the important fixation zones. And when you have this diffuse uptake across 3 zones, as you can see over here, this is basically consistent with an abnormality. Most likely it's loosening, and in this case we have loosening. But if you didn't have this lucency over here, and then you can actually call it aseptic loosening, or we have a loosening over here.
And that's a very interesting case. And when we look at the CT, which is actually very well performed, and there are very few artifacts, we see only very thin osteolytic changes close to the screw.
Yes, exactly.
So the screws are way below 1 millimeter.
Exactly.
And, but there's this intense uptake. So you would say that both screws need to be replaced because they have too much of bone metabolism?
Exactly. The screws, if you can see here, you have some kind of cystic lucency over here, even though it's less than 2 millimeter, but you have the cystic lucency. It's really obvious over here, and this is abnormal. So we don't usually see this lucency over the bone prosthesis interface. So this is consistent with a loosening of the acetabular component. We should not see this under normal conditions with a total hip replacements with fixation screws around the acetabulum. So this is basically loose.
And this case is also interesting based on another feature on the right hip, because we see there's avascular necrosis of the femoral head.
Over here, yes, exactly.
And I wonder why there is no uptake in the SPECT. So is this an older lesion, or what's your experience with femoral aseptic necrosis?
So in necrosis, in avascular necrosis, or the most common term that is now used, osteonecrosis of the femoral head. If you have a necrotic segment over here, like we say here, this is some kind of crescentic density. If it's necrotic, it's not going to show uptake. What we usually see in the SPECT, on the SPECT or the bone scan, is the reparative phase, or the reparative or bone remodeling around this necrotic region. So this is not going to show any uptake because it's necrotic, but sometimes you can see uptake around it. You can see uptake or peripheral rim of uptake around this region, or you don't, or sometimes you don't really see this this kind of uptake. When do we see uptake around avascular necrosis? When there is subchondral fracture. When it's when we're in stage 3, when there is subchondral fracture, regardless if it's more than 2 millimeter or less than 2 millimeter, this is when we usually see the uptake. In stage 2 and stage 1, we can see uptake, but usually we see this photopenia around this region and peripheral rim of uptake. But we don't really need to see this unless there is a reparative phase. This patient had bilateral avascular necrosis, and she had hip replacement on the left side, but still they didn't intervene and on the left side. So again, and if we look at the femoral stem, it is in normal position. We don't have any kind of hardware fracture or dislocation, and there is a uniform tracer uptake around the femoral stem. So post-operatively, you should expect to see uptake around the proximal part of the greater trochanter and lesser trochanter. So this is zone 7, and this is zone 2 around the lesser trochanter. And usually we can see, especially in uncemented femoral stem, we can see persistent uptake around these regions on planar imaging. So in conclusion, this patient had, this was actually aseptic loosening of the acetabular component. I say aseptic loosening because if we want to call it septic loosening, if we want to be definite about calling this a septic loosening, we should see fuzzy osteolysis over here. We should see periosteal reaction. We don't really see this regular cystic lucency over the acetabular components. And when you see this cystic line over here or sclerotic line over here, and you have this lucency, you should really think of aseptic loosening. But again, you need to do a white BC scan to come up with a definite diagnosis. So this is regarding the first case.
Great.
And yes, this was avascular necrosis. She had bilateral avascular necrosis.
So let's look what else you have. And meanwhile, hello Imane for staying here and for being our fan and staying in the live stream.
I remember him.
So this is now case 1. Maybe you go to case 2.
Yes, I'll go now to case 2.
To case 2.
This is a really nice case, and this is a very interesting case. Okay, so this is again the other exported VRT, CT, or fused MIP images. So you can either email us on how to do these images if you're just using OzRX, or we can do that in another session. But this is really nice, and it's a good marketing tool again for the referring physician. So you can see this is the hip replacement, and you have this uptake around the distal stem, and the medial region. We have mildly focal uptake over here. This is not relevant. So let's look at the history. This is a 68-year-old male with cementless total hip replacement. This was 7 months ago. So I don't like to do these scans if it's less than 12 months, because you might have some kind of residual bone remodeling or activity, and this is just physiological. Usually we do the scans after 12 months. This patient was complaining of right mid-thigh pain. The onset was gradual. It was 1 month after surgery, described as progressive, increasing in time, and it was alleviated by rest and increased by walking and going down the stairs. The inflammatory markers, this was a bit query. He had fluctuating inflammatory markers. The CRP was fluctuating between 66 or 65 and 150. Anyhow, the last one was around 30. So all these cases we're presenting, we have a final diagnosis intraoperatively. Now, I'm gonna jump into the coronal images. As you can see, these are multiplanar reconstruction images. I went through the femoral stem to get the proper diagnosis. Okay, so these are not orthogonal axial coronal and sagittal planes. What I usually do is the axis, I would point it at the femoral stem, and the long axis and the short axis, I would do it on the axial images at the femoral neck, and I would reconstruct the images accordingly. So what you're seeing here is multiplanar reconstructions. So in this case, let's take both the fused and CT images. So here you have this intense uptake around the femoral stem. And if you want to look at the zones, this is zone 4, and this is zone, this is 4, and this is 5, and this is zone 3. If we look at the femoral zones, the groin zones, below the greater trochanter around here, this is zone 1. And below the greater trochanter, we have zone 2. You have to divide the zones in an equal pattern. So here we have zone 1, here we have zone 2, and here we have zone 3. This is zone 4, and this is zone 5. So you can say we have intense uptake around the femoral stem or the femoral tip, or around zone 3, 4, and 5. And if we look here at the CT images, you can see that the femoral stem is in a valgus position. We don't like to see this because we want, in a varus position. We don't like to see this. We want the femoral stem either to be centrally positioned or in a valgus position. Even though varus position of around 4 to 5 degrees is tolerated, but this, I think, if I remember correctly, this patient had this the femoral stem at around 4.3 or 4.5. So we have this uptake over here, and we have this uptake over here. If we look at the femoral stem over here, you can see this some kind of a big lucency around zone 1, and we don't know, is this a redo hip replacement, or this is the first time this patient had a hip replacement. Sometimes we don't get the full history from the patients or from the referring physician. But nonetheless, we have this big lucency over here. It was around 5 or 5.4 millimeter, and we have this uptake here, and we have this uptake over the medial or zone 7 region. Okay, so now let's take a look at the sagittal images. Again, we have the same kind of uptake. We have uptake over here, and we have uptake around the femoral stem. So let's go back to the coronal images. you can see that the stem shoulder, it's somehow low in position relative to the greater trochanters. This should be a bit higher in position, okay? But the thing is, you need to see the post-op X-rays to confirm that this has migrated in a more inferior or a lower position, to confirm that there is subsidence. So when I talked to the referring physician, this was not evident on the post-op images, and he was surprised actually that this was in a varus position, and we have this big lucency, and the stem shoulder is a bit lower relative to the greater trochanter. So let's try to make sense of everything that we see, because we don't really see any kind of lucency around the diaphyseal femoral stem. What we see is just this lucency over here. Okay, so let's take a look at the report. The femoral stem is seated within the medullary canal in a varus position, and I say varus because, again, when the tip is pointing to the lateral cortex, this is in a varus position. When it's pointing to the medial cortex, this is in a valgus position, and we want it to be in a valgus position, or if it's pointing toward the medullary canal, this is in a central position. We like valgus or central position. If it's varus, it is susceptible to subsidence, to loosening, any other kind of abnormalities. Okay, so this was 4.8. It's not 4. And how we measure this? Basically, you do a perpendicular line along the femoral stem and another one along the femoral shaft, and you measure the angle between them. If it's more than 5, it is suggestive of an abnormal positioning of the femoral stem. Again, there are reports that says that between 5 and 7 degrees is tolerable, but it should be considered as abnormal when you see any kind of uptake. So this lies relatively inferior to the greater trochanter, suggesting a possible distal migration. So when I talked to the referring physician, he told me that this was not actually the current position of the femoral stem, and it was higher in position. So he suspected subsidence. There is focal calcar cortical resorption corresponding to intense tracer uptake. So this is the calcar region, and this lip over here, let me bring up the CT part. So this is the calcar lip, and this basically it protects against subsidence. It's like defensive measure against subsidence. When you see this lip over here, we try to avoid any kind of subsidence. But when you look over here, there's intense uptake, and there is some kind of osteolysis beneath this calcar. Let's take a look at the axial slices. So here you can see the intense uptake around the lesser trochanter or at the calcar or the medial region. And you can see there is a bit of a bone remodeling. And you can appreciate there is some kind of osteolysis involving the cortex. And this is all showing intense FDG, intense tracer uptake. So under normal conditions, we should not see this appearance. You can see mild to moderate uptake around the calcar region because there's constant bone remodeling around there, but not in that extent. And we really don't want to see this kind of osteolysis of the cortex around the medial region. And again, there is linear osteolysis involving the femoral zone 1. It was actually 5.8 millimeter. Let's take a look at that. So this is zone 1. You can see this lucency over here. Okay, this is abnormal. We don't want to see this. If it's more than 2 millimeter, you should suspect loosening in the femoral stem. And it was not showing tracer uptake. We'll come to that. There's an intense perfusion and delayed tracer uptake involving the distal tip, as we saw in zone 3, 4, or you can just say the distal tip, non-focal mild tracer uptake around the remainder of the femoral cortex that was medially. But when I exported these images to OSRX, you cannot really appreciate the mild uptake, but there was mild uptake around the medial cortex, femoral cortex over here. Okay, so let's try to put everything together before we jump into the conclusion. So, first of all, we have a suboptimal proximal fixation, okay, and there was a varus seating. So, if we look at the mechanics, the stem it was at 4.3 or 4.5 varus, which is somehow tolerated. So the load is concentrating medially and reducing uniform metaphyseal engagement, okay? Although varus alignment of 4 to 5 can be tolerated. And when radiologically, what we see on CT is varus stem positioning, as we saw on the CT part, and on the coronal images. And the collar tends to favor medial contact. So this is varus positioning, and this is medial contact over here. So we have a stress bone remodeling, abnormal stress bone remodeling over this region. So what happens next? Early micromotion prevents proximal osseointegration. So what you really need to know from the referring physician is this metaphyseal fixation or is this diaphyseal fixation? Because in uncemented hip prosthesis in the femoral stem, it really makes a difference. When you see the lucency around, this was a metaphyseal fixation, so we are looking, interested in lucencies around this region. When you see this lucency over here, and this is a metaphyseal fixation, you have to think that this is probably abnormal. And what happens is, because this is loose, and you have this intense uptake over here, the femoral stem, it starts wobbling back and forth medially and laterally. It's like a wobble effect. So you have this fixation over here, and this is a loose part, so it starts to abnormally moving back and forth medially and laterally. Okay, so we have early micromotion that prevents proximal osseointegration, and as you can see here, we don't have the fixation around the metaphyseal region, evident by this large lucency over here. So repetitive micro movement at the proximal bone implant interface, it leads to fibrous fixation. What happens after 6 months, or when chronically, what happens, there is no osseointegration. What happens over here is fibrous fixation, and we don't want that to happen. So radiologically, what you see is a radiolucent line around, depending on the fixation zone. So in this case, we have a radiolucent line around a zone 1. It was 5.4 millimeter. This is very large. So if it's more than 2 millimeter, usually this is pathologic. 5.4, this is extremely large, okay? So you can't dismiss this. Too large to dismiss as early remodeling. And the post-op X-ray, this was what is most important. They did not see this radiolucent line in the post-op X-ray. So what the femoral stem tries to do is find a suitable position okay, for it to basically to resolve its place around the femur. So without proximal fixation and growth, the stem migrates distally, and it keeps migrating unless it finds a proper mechanical equilibrium. And how do we see this? The interval change in the serial radiographs or CT, depending on what the patient did. So you can have serial X-rays or serial CTs, and if we see this changing in position over a period of time, so you have to think that we have definitely a subsidence. Okay, so as I said, interval change in serial radiographs or CT, The collar-calcar relationship might change in the medial aspect of the proximal part of the femoral stem. In this case, the femoral stem shoulder lies relatively inferior to the greater trochanter, suggesting a possible migration. Now, this is relative description because we need the previous radiographs to describe if there is a subsidence or not. So what you can do if you don't have the previous radiographs is draw a line over the most superior aspect of the greater trochanter, and you copy that and you find the most superior part of the shoulder stem. So if, let's say, we have the most superior part of the greater trochanter over this region and the most superior part of the shoulder stem of the prosthesis over this region. And if you measure this distance, if it's around 2 to 5 millimeter, usually this is normal. If it's more than that, this is highly suggestive, basically, of subsidence. But this is sensitive, it's not specific. You need to look at the previous radiographs. In this case, it was, I think it was around more than 5 millimeter in distance. So it was highly suggestive of subsidence. And when I called the referring physician, he told me that this lucency was not evident, and this appearance was not evident in the post-op images. So this is highly suggestive of subsidence. After that, what usually happens? Without femoral fixation, proximal fixation around the fixation zone in the metaphyseal part, the stem migrates distally few millimeters, regardless if it's few millimeters or centimeters, until it finds a new mechanical equilibrium. So we see the interval change on serial CT or radiographs, collar relationship change. And as I said, in this case, the shoulder stem relatively lies inferior to the greater trochanter. So what happens is the varus alignment and collar contact can cause focal medial compressive overload, which leads to bone remodeling, resorption, sclerosis, or osteolysis, while the unstable interface drives resorption. So what we see on the CT is medial calcar osteolysis, like what we see over here in this CT. You have a medial calcar osteolysis. Okay, and usually it is accompanied by proximal interface lucency, which we see in zone 1, and calcar remodeling. The load.
Ziad, we have a question about the if there are artifacts or like metal interface artifacts coming from the CT reconstructions, if they can simulate these lucencies, and how do you cope with that?
Yes, they can simulate lucencies, but when you have metal artifacts, the lucency. Okay, let me show you the image. So here we have, this is definitely a metal artifact, and here in the proximal region, let me just. This is definitely a metal artifact. But here, we don't see the metal artifact. You can see this line over here. This is a metal artifact, but you can see the cortex over here. Now, this is not a metal artifact. You cannot say this is a metal artifact. You can see this very thin line over here. This is probably a metal artifact, but the rest of this region is not metal artifact lucency. So what you need to do is expand the window of the CT, okay, in order to reduce this metal artifact. The other way to do it is to increase the CT energy, the X-ray energies, in order to overcome these metal artifacts. So this here, this is not related to metal artifact. The horizontal lines over here, you see, this is metal artifact. You need to get used to these images under normal conditions if you don't have a metal artifact reduction. If I go here into these slices, this is definitely a metal artifact. But I can see the cortex over here.
Very well explained. Thank you. Very well explained.
I can see the cortex. So you have to expand the window of the CT in order to reduce this metal artifacts. If you have a metal artifact reduction, that is great. It really helps. But if you don't, like I do, I don't have a metal artifact reduction. So you have to do with what you get. So not to expand this case for a very long period of time. So you have varus alignment and collar contact that is causing focal medial compressive overload and unstable interface. So what we see under these conditions is medial calcar osteolysis, and it is accompanied, can be accompanied by lucencies or bone remodeling. So the load shifts distally to the distal stem, okay, and there's going to be some kind of toggle switch. Toggle switch, when you have this femoral stem wobbling medially and laterally, and it is here fixed, but proximally it is unstable. It's not fixed, so it starts moving medially and laterally. Okay, so the repetitive micromotion at the proximal bone implant interface leads to fibrous fixation, and what we see here is probably a fibrous fixation, even though this is loose. This is definitely loose, but it can be also a fibrous fixation, and this was actually confirmed intraoperatively. And a radiolucent line at Gruen zone 1, which is what we see in this case. It was 5.4 millimeter. It's too large to dismiss, especially if it's progressive, in addition to the post X-ray images that did not show this radiolucent line. So eventually, without fixation, proximal fixation, the stem migrates distally a few millimeters until it finds a mechanical equilibrium that it settles in. And what we see radiologically is interval changes in the serial CT or radiographs. But if you don't have that, so you can look at the femoral shoulder. It should be a bit higher if it's in varus position, if you have intense uptake over here, as we see in this case. So you have to think that what we have here is subsidence and mechanical loosening proximally. And this was actually confirmed intraoperatively. This was one of a bit of a difficult case to me. So if we want to take a look at everything we saw in this case, we have a combined pattern of varus positioning of the femoral stem, subsidence, which was evident clinically, and what we saw on imaging, large proximal lucency, medial calcar osteolysis, proximal distal tip uptake on the SPECT CT. So this was failed early osseointegration and mechanical instability with early loosening and the distal stem stress transfer. So what you see here is this was actually fixed intraoperatively. They could not, this was really fixed intraoperatively, but proximally it was very loose. So this patient had a redo fixation. So it's not just what we do with SPECT CT is septic loosening or aseptic loosening. You can, based on the metabolic pattern of the bone uptake, we can say that there is abnormal stress around certain regions of the prosthesis. I know this was a long case, but I
have a few questions regarding this case, maybe also for clarification. So the migration, the axial migration, is something that's actually wanted a bit by the orthopedic surgeon, and they expect it. So they calculate with it, maybe 1 or 2 centimeters.
There is expected a bit of migration of the stem, but in this case, this was significant. This was really significant. So one way to do it, as I said, is to draw a horizontal line over here, and you copy that onto the most superior part of the shoulder stem, and you measure the distance. If it's more than 4 to 5, this is sensitive, it's not specific, you can suspect a migration. And this shoulder stem should be higher in position according to the post-op X-ray. So when you compare it to the post-op X-ray, you can definitely say that there is migration of the femoral stem. And when you have this lucency and you have this intense uptake over here, this is
also you said you spoke about fibrous fixation compared to osseous fixation. Would you expect different SPECT patterns in these two types?
Yeah, exactly. So in fibrous fixation, you don't see uptake. So you can have fibrous fixation around, let's say this is the acetabular component, and this was loose. So chronically, over a long period of time, you can have some kind of fibrous fixation, and this is not going to show uptake, but you can see a very large lucent area around the acetabular component at the and the bone interface. So even if it's not showing uptake, you have to say that this is loose, chronically loose, and there was some kind of fibrous fixation around this region, because you don't. When you have total hip replacement, you don't want to see any kind of lucency between the bone and the prosthesis interface.
And then I have a third question, actually. So you mentioned the WBC scan if there's suspicion for septic loosening. So first you do the bone scan, the technetium scan for the osteoclasts. And then how long do you need to wait to do the next scan? 2 days, 3 days, or the next day?
It depends on the traces. So if you're using indium, you can do it the very next day, or gallium-67, you can actually do it on the same day. You can actually do simultaneous, the bone scan and the indium scan together, because each have different gamma rays characteristics. So you can do both in the same session. But if you're using a technetium tracer, you can do it the next day or the next within the next 2 days. The half-life is 6 hours, so you don't expect to see much tracer uptake after 24 hours or after 48 hours.
Okay. So let's pick one final case.
This was a long case, but it was very interesting because you can pick up these abnormalities over here. So I'm gonna do this case because we did acetabular cases. So this is a 24-year-old male, and he had 2 prior hip replacement surgeries. The first in 2019, the second one was 2 years ago. He presented with a progressive mechanical left hip pain with functional limitation aggravated by walking and walking up the stairs. He had no focal, regional redness, swelling, fever, or any kind of systemic symptoms to suggest that there is an infection. But again, let's take a look. This is the blood pool phase. So you can see there's this intense uptake on the early phase or the blood pool phase. And this is the delayed phase. Again, you can see this diffuse, intense, or heterogeneous uptake around the femoral stem. And this is the planar. I'm showing the planar images because not everyone has SPECT CT, so I want them to correlate these findings with planar imaging. So you can appreciate that there is intense uptake around the femoral stem. So let's take the SPECT CT. I only included the coronal and sagittal of the early phase. You can clearly see there is intense uptake in the early phase around the femoral stem. This is the sagittal image. And let's take a look at the coronal. Now, I did not do multiplanar reconstructions over here because I really did not need them. So you have this diffuse intense uptake around almost all the femoral zones on the coronal images. And it is, if you can, let me zoom in. You can see this osteolysis over here. You can see this cystic sclerotic line over here. And this was more than 2 millimeter, definitely. So you have, and this is a large osteolysis over here. You have intense uptake corresponding to diffuse radiolucent line. Let me just remove this. You can see this cystic sclerotic line over here, and this is the bone prosthesis interface. This is the uncemented prosthesis, and it is showing intense tracer uptake, and it is corresponding to a large radiolucent line around all the femoral stem. And when we look at the acetabulum, it is not showing this significant uptake. You can see in zone 1, under normal conditions, you can see uptake because you have constant bone remodeling over here. And sometimes you can see some kind of osteophytosis over here because the load transfer, it is around this region, and so the bone responds in bone remodeling. So this is why you see sometimes uptake over here and osteophytosis over here. But this is normal. When you see uptake over here and it is not corresponding to a lucency, this is normal, just normal uptake in zone 1. This is definitely abnormal according to the CT and to the SPECT CT. Let's take a look at the axial images. So you can see there's intense uptake around the sacroiliac joint. And here, you can see a bit of periosteal reaction, cortical thickening, but we don't see what we usually see in septic loosening, osteolysis, cortical disruption, endosteal scalloping. We don't see these findings over here. We just see periosteal reaction, probably a bit of cortical thickening or sclerosis, and it is all showing intense FDG uptake. Now, what I want to show you is, again, the positioning of the femoral stem. So again, we have this calcar over here to prevent subsidence. When you see this slip over here, this is basically to prevent subsidence and to stabilize the femoral stem. But we need to see it above the cortex, and here it is below the cortex. We can see it below the cortex. And again, if we draw a line over here of the greater trochanter and the shoulder stem, if we measure this distance, again, I'm not stressing that this is diagnostic, but if it's a bit large, if it's more than 5 millimeter, so you have to suspect that there is some kind of subsidence. Okay, and this calcar region, it should be above the cortex because it needs to prevent subsidence. There should not be subsidence in this case. And this was actually confirmed intraoperatively. This patient had femoral subsidence. You can see here the lesser trochanter, and you can see the lip over here. It is a bit low compared to the lesser trochanter, and even the shoulder stem, it is a bit low compared to the greater trochanter. So this was actually aseptic loosening, even though we see this diffuse uptake on the early phase and delayed phase. If in these cases, if you want to confirm that this is infection or septic loosening or aseptic loosening, you really need to do white BC scan or at least an FDG PET scan. So again, this was a bit in a varus position. You can see, if you look at the femoral stem, it's pointing laterally. In comparison to the femoral shaft, it's pointing laterally. So this is in a varus position, and we don't like to see a femoral stem in a varus position. Sometimes it is intentionally done, but generally speaking, we don't like to see that. And the femoral shoulder, it lies relatively inferior to the greater trochanter at approximately 35 millimeter, using a vertical. This is how you can do the wording in your report. Vertical offset between the superior lateral stem shoulder and the greater trochanter, suggesting a possible subsidence. To confirm this, again, you need to see the post-op X-ray images or the CT. And we have diffuse perfusion and delayed tracer uptake involving all the femoral zones. And again, we have a large sized osteolysis over here, as you can see on the CT. And even over here, you can see these are cerclage wires to support the fixation of the femoral stem. But unfortunately, in this patient, there was a subsidence confirmed intraoperatively, and there was aseptic loosening around the femoral stem. So again, you need to do, in this case, to confirm if there is septic loosening, you need to do at least FDG PET scan. And if you have a white BC scan, if you can do a white BC scan, you should do that to confirm an infection or a septic loosening.
But would FDG PET scanning be overkill just to decide on the hip arthroplasty?
So if the referring physician doesn't want to do any kind of intervention, joint aspiration or biopsy, then you have to do a white BC scan or an FDG scan. We don't have a white BC scan in Jordan, so we do an FDG scan. And if it's showing a congruent intense uptake around the femoral stem that is compatible with what we saw on the SPECT CT, then this is probably a septic loosening. Unfortunately,
what SPECT pattern would you expect in metallosis?
Okay, so in metallosis, this is a really good question, and I think I had a case with the FDG PET. So with metallosis, what you get two different kind of patterns. So you have a large size mass around the prosthesis, and it is showing a peripheral rim of uptake. This can tell you that you have, of course, we see this on metal. Usually we see this with metal on metal prosthesis. You have a large soft tissue mass that is centered around the proximal part of the prosthesis, and it is showing peripheral rim of uptake. But definitely you need to do an MRI to do the diagnosis. Or sometimes you have granulomas that forms around the bone prosthesis interface, and you have industrial scalloping around the bone prosthesis interface. So you get these curvilinear lucencies, and they usually do not show tracer uptake. This is how we see them.
Okay, cool. Okay, so this is very nice. So we have seen 3 great cases. Of course, when experts are demonstrating, this is quite a wealth of information. So if radiologists who are not trained with nuclear medicine methods are looking, they just see the pattern, the activity, but you explained very nicely the different things that can be done. So here, before we finish, a brief view on our page, BerlinCaseViewer.com. We have 2 main options right now. So the master series is now over. It was last week, and we do a new master series maybe at the end of the year or next year on the ankle, maybe shoulder. We're also looking into the lung and other organs. And then we have the online academy, which is basically the general radiology teaching environment, and we have the nuclear medicine academy that we are showcasing today. And so we have some stuff in the free tier, and then we have the full information about stuff starting with technical principles, three different lectures. Then we also have like some of the hip cases. They are available here in this section, and especially foot cases.
Yeah, exactly.
And then we have cardiac cases.
Probably we have the largest library of hip and knee prostheses available online for regarding SPECT CT. We have a lot of really nice cases.
Yeah, and they are all in this module here included in this one, and also we have quite interesting other stuff that you can explore. And we will also present in the second half of the year focused learning pathways, learning tracks that are just bringing the SPECT CT and taking out the PET CT imaging, because some people would like to learn more about MSK applications. Yeah. Others would like to know the basics of oncology. Yeah. So we are splitting this apart so it gets more affordable for those who want to learn it as a
I'm
package.
also starting a bone scintigraphy module. So we're going to have probably around 5 or 6 modules. And each module basically is going to cover the whole bone scintigraphy discussion that is needed for residency program or in daily practice. We're gonna focus on plantar imaging, because this is what everyone struggles with. So we're gonna do that. Yeah.
So right now we already have some of it. So we have the bone scan series. It's 3 parts. So the first one is here in the free tier, and then we have the second one and third one included in, I think, the MSK part, where we have the bone scan. Yes. This is part 2, and this is part 3.
Yeah. So if you're a resident, these 3 sessions is everything that you need to know about bone scans regarding the pharmacokinetics and why the uptake happens in physiological conditions and pathological conditions. This is basically everything that you really need to know.
Great. So this concludes our session. Thank you very much, Ziad, for
we have 2 cases. I was hoping to do more than just 2 cases. The second one was really difficult, but it really highlights the value of SPECT CT, not just in diagnosing septic or aseptic loosening, but in detecting the abnormal biomechanical loading or stress transfer around the femoral stem. So you can detect these abnormalities, and no other modality can do that. So if you're really familiar with the biomechanics of the prosthesis and what you're looking at in the SPECT CT and the CT part, you can come up with the most probable diagnosis, such as in this case. It was a really interesting case. I was really happy with the diagnosis, and the referring physician was really happy. He called me instantly after the surgery. He told me that everything that I wrote in the report was spot on. So it's not just about septic or aseptic loosening. You can detect other abnormalities with SPECT CT.
So you see the nice comments we are getting, and also those of those of you who came in late, you can keep the cases for some time, 4 weeks, and also when you enter this code, or when you look at the QR code, which I embed here, and also of course this is streamed on YouTube, so you can rewind it on YouTube and also within our academy. So thank you for being here, and thank you for having a good discussion with nuclear medicine. See you, and bye-bye.
See you. Bye-bye.